Hi, here is a 27-year-old man who wanted to get rid of this white thing in his eye. He had sustained a penetrating injury with a stick when he was 12 years old. Since then, the vision has been poor in that eye and subsequently he has developed this white thing. Now he has come to the hospital with two demands. He wants to see well in that eye and also get rid of this white thing, which he is very conscious of cosmetically. Pupil reaction was brisk to light and the B-scan showed a normal posterior segment. Detailed examination shows that this was a membranous calcified type of traumatic cataract. The anterior capsule looks to be open and there is also a high likelihood that the posterior capsule is open too. And in between these two open capsules, as the anterior and the posterior capsule, there is this incarcerated lens matter which is also calcified. Now we have got certain challenges to deal with. Remove this membranous cataract and preserve enough capsular support to place a posterior capsule lens. And then hoping that the visual outcome and the cosmetic rehabilitation is good. The patient was explained and informed consent of guarded visual prognosis was taken and a possibility of peripheral white opacity is still remaining since we needed to utilize this anterior capsule as a support for placing the posterior capsule lens. The reason for taking a guarded visual prognosis is the possibility of an amblyopia existing in this eye even if the retina happens to be normal. Intraoperatively, I am anticipating multiple scenarios and I am ready to deal with these scenarios with different lens options. So I am ready with a single piece lens for the in the bag placement if there is an opportunity, multi-piece IOL-4 sulcus placement and an iris claw lens for the worst case scenario. So my plan for the surgery is that first I'd like to delineate the anterior capsule and see what is the extent of tear, identify the posterior capsule and see whether it is torn, and then try to dissect out the lens matter which is stuck in between these two capsules and see if I can remove it without damaging or compromising the anterior and the posterior capsule. In the best case scenario, if I'm able to clear out all the lens matter, then it might be possible for me to place the lens in the bag itself, which looks to be slightly unlikely. But the challenge which I'm expecting is to deal with this fibrotic anterior capsule and the adhesions of the lens matter with the anterior and the posterior capsule. And that is going to be really tough for me to remove. Of course, I'm ready with my anterior vitrectomy unit and that's going to play a major role in this case. Let's see how things turn out. The surgery is being done under topical anesthesia. The two side ports are being created. Anterior capsule is stained and the eye is pressurized with OVD. I'm consciously making a sclerocorneal incision in this patient. The reason being, if I need to use an iris claw lens, I can extend the scleral incision because the iris claw lenses are all in PMMA, so we need to have a wider incision. So that was the idea behind planning a scleral incision for this patient. The first goal now is to identify all the different structures. I want to create space, delineate the tissues so that I want to know where the anterior capsule is, where is the posterior capsule and what is the extent of the tear. I'm using a combination of visco and blunt dissection to identify these structures and simultaneously to create some space so that the lens matter can be maneuvered out. I'm using the blunt cannula of the OVD for dissecting. Since it wasn't so effective, I have switched on to a much more flatter device. This is an iris spatula which is very thin and flat so that I can introduce under the capsule and sweep it across to deal with all the adhesions of the anterior capsule with the underlying lens matter. While trying to dissect, these are the fibers which are looking slightly ominous. They don't look like lens fiber. I don't know whether thickened vitreous fibers there. Not sure about that. The hands are switched. I'm trying to do the same thing from the other quadrant. And I'm trying to dissect out the anterior capsule from the underlying lens matter. This area, the zonule seems to be very weak as the bag is getting displaced. So another area of concern for me. At this point, I'm thinking that the posterior capsule was already open and these fibers could be just thickened vitreous fibers. I'm not sure. So I thought the posterior capsule is already open. Let me begin by doing vitrectomy. Before that, I would want to inject diluted triamcinolone acetate and then start using my vitrectomy cutter. It's mandatory for us to realize that whenever there is a suspicion of any vitreous bands or membranes in the antechamber, it is not worthwhile to continue dissection until we tackle with these fibers. The suspicious fibers are first dealt with, and then the cutter is then used to clear off the central area. And now we can see that the central area is clear and which is devoid of any posterior capsule. The exact location of the existing posterior capsule I'm not able to delineate still because of the overlying lens matter. Now the real challenge now is to get the lens matter out of the eye without any of it dropping into the vitreous, because these are all calcified lens matter long-standing, and it is very much adherent to both the overlying anterior capsule and the underlying posterior capsule. So I need to remove this sequestered lens matter without them dropping into the vitreous. This portion of the thickened lens matter is being dealt with the cutter itself under direct visualization. I'm trying to aspirate the lens matter with the cutter itself. I'm just going to engage the lens matter and then bring it to the pupillary margin and then cut and aspirate it. But it's very difficult. I'm not able to get the hold of the lens matter. So that idea is not working. So I need to find some other way of dealing with this lens matter. I am back with my iris repositor. I'm trying to disengage these thickened lens matter from the anterior capsule and the posterior capsule and try to loosen them and trying to bring nearer the pupillary axis so that they can be cut and aspirated out. So far there is just a limited amount of success. So the instrument is swapped with the cutter and whatever little lens matter had come out is being taken care of. Now remember that all these maneuvers are being done in a scenario where there is no vitreous around. So we can't dissect or move any instrument whenever there's vitreous in the vicinity. So the vitreous is already been taken care of and we're just trying to deal with this lens matter. I've changed the strategy. I'm trying to go in with my irrigation cannula and then try to mobilize this adherent lens matter into the pupillary axis where it can then be aspirated using the cutter. Although the lens matter has been loosened a bit, but I'm not successful in mobilizing the lens matter to a point where I require. So again I go back to my iris repositor, and this time with the chamber being maintained by the irrigation coming through my left handpiece, I am successful in mobilizing the lens matter away from the anterior and the posterior capsule towards the visual axis. So this chunk of lens matter is now free. The cutter is reintroduced into the eye and this lens matter is then consumed by the vitrector. With the same cutter in cortex aspiration mode, some of the cortex which is amenable to aspiration is aspirated out. The irrigation handpiece is again used to mobilize this calcified lens matter. It is coming in piecemeal and a small portion of it is being mobilized into the antechamber, which is then taken care of with the vitrector. So the strategy of levitating the lens matter out of the capsular fornices using the irrigation handpiece is working well. The lens matter is gently maneuvered out of the capsular fornixes through the visual axis into the antechamber. Then it's taken care by the vitrector. The capsular bag is looking significantly clean now. I'm using the cutter itself to enlarge the anterocapsular opening. So I'm using the cutter in the IA cut mode, where I'm using a cut rate of about 1000, a flow rate about 14 centimeters and a vacuum of about 300. So this is going to help me to cut this fibrotic anterocapsule. I want this capsular margin to be big enough. It's not visible cosmetically. At the same time, it gives enough support for my intraocular lens which is being placed in the sulcus. The anterocapsule trimming is done all around so that I have an 4 to 4.5 millimeter opening in the visual axis. Some of the remaining cortex is being aspirated by the vitrector. And this part of subincisional lens matter, I'm just trying to levitate it using the irrigation cannula. Fortunately, it just flows out into the antechamber. It is then expressed out through the sclerocorneal incision. The last bit of cortex and also the thickened lens matter is eventually taken care of. Now we're ready to implant the lens. The plan is to place a multi-piece lens into the ciliary sulcus and then try to achieve an optic capture through this capsulotomy which we have created using the vitrector. Cohesive OVD is being used under the iris to create some space above the anticapsule. The multi-piece lens is gently maneuvered into the eye. The distal haptic lands above the anticapsule and gently the trailing haptic is guided in the ciliary sulcus under the iris and above the anticapsule. Now before doing optic capture, I need to remove the OVD which has gone behind the capsule into the vitreous cavity. With the irrigation in my left hand and the cutter in my right hand, cutter is introduced under the lens and it goes below the level of the posterior capsule. Then I'm going to aspirate out all the OVD which is there. Obviously at this point there is hardly any vitreous in this region. Once I'm satisfied with the removal of the OVD, now is the time to achieve optic capture. With the fluid coming in from the irrigation handpiece through my left hand, I'm using a Sensky hook just to tap the optic of the lens back posteriorly so that it gets engaged or locked in the anticapsular opening. As the optic capture is being done, there is a small area of zonular dehiscence which is evident where the edge of the capsular bag is fluttering, but nevertheless it's a very small area. The rest of the capsular bag seems to be sturdy enough. The ovalization of the capsulotomy suggests that the optic capture is perfect and the lens looks to be very stable and well centered. The remaining OVD in front of the lens is then aspirated out. Before closing, I would want to do a small peripheral iridectomy because this eye can have inflammation and I don't want any pupillary block to happen. So I'm using a diluted pilocarpine to constrict the pupil and using the cutter itself in the IA cut mode, I'm doing a peripheral iridectomy in the superior quadrant. The technique is very simple. So I'm going to use the aspiration mode first to engage the iris, then just give a couple of cuts. The cut rate is set to 100. So I'm just pressing the pedal just a little bit so that a couple of cuts are there and you have this beautiful iridectomy. Time to close. Before removing the irrigating handpiece, I'm just trying to hydrate the wounds because this is an young eye and there's a lack of scleral rigidity. There's a chance of chamber to collapse. So I'm just trying to hydrate the wounds. We need to spend a little bit more time in these younger patients for the wounds to seal because of the lack of scleral rigidity. So just wait for a couple of minutes so that once I'm sure that the wounds are pretty well sealed, that's time to call it a day. So these are the first day post-op pictures. The pressure was recorded to slightly on the higher side and you started with anti-glaucoma medications. By 1 week, the cornea is very clear. And these are the pre-op and post-op pictures in the single frame. So from this, we have achieved this, which has got excellent cosmetic results and a decent visual outcome as well. The patient's vision is around 618, but the expectations of the patients will be so high. He's still complaining that he still can't see the last two lines. And obviously this is because of the residual amblyopia, and you've explained, but surgeon's life is tough. You need to meet the expectations. Nevertheless, it's always satisfying to deal with these complex cases and it challenges you, and this is what makes a surgeon's life interesting. To summarize, I think the biggest challenge here was to maintain the opening of the anticapsule and deal with the sequestrated lens matter which was trapped between the torn anterior and the posterior capsule. This could be dealt only after doing the limited anterior vitrectomy. Then I was able to successfully dissect out the attachment of the lens matter with the anterior capsule and the posterior capsule, then levitate it using an irrigating handpiece. So this method worked for mobilizing the lens matter into the antechamber, which was then taken care of the vitrector. Obviously, once the lens matter was cleaned and we had enough capsular support, a multi-piece lens was placed into the sulcus with optic capture. So that was it. Thank you for watching and hope you found this helpful.